The Chinikum project started in September 2013. It's a qualitative project looking at developing services for South Asian families. The reason why we work with families and why we highlighted families is because we found from other research we'd done before with Diabetes Scotland that South Asian families make decisions together. With each family, not every single person will be living with diabetes. It might only be one member of the family that's living with diabetes, or it might be two. But there can be a potential for up to 5 members of that family being involved.
If you're from a South Asian community, then you do have a much higher risk of developing type 2 diabetes, so up to 6 times more likely than the white European population.
Diabetes is like a holistic condition. Yes, there's the actual condition itself and the complications that you have from those conditions, and that's about all you're able to do with the GP and highlight. But there's also many factors like your environmental factors, your hereditary factors, if you're suffering from money issues at that precise moment in time, and how the stress is affecting the control of your diabetes, your living conditions, your income and how much you can afford to buy in regards to food and what types of foods that you can buy. So all these different factors affect that person, but they're just not able to communicate that with the GPs.
For many South Asians, we know this from research, is that they like to be able to relate to their healthcare provider. And often that might mean a linguistic connection, or it might mean a cultural or religious connection.
You know, with the NHS, there is always a sort of one-size-fits-all kind of approach, you know, because it is a national service, so it's difficult always to tailor it to specific communities.
Language aside, often when it comes to managing a condition, it requires people with diabetes to modify their diet and their lifestyle, and lifestyle often means exercise and physical activity. So diet is very different, we know that. So giving advice that is tailored to the South Asian diet will help people engage and apply what they are taught. And secondly, when it comes to physical activities, appreciating the sensitivities when it comes to undertaking a physical activity, because you have to respect dress code and interaction between genders. Then if you're giving something that is actually practical, then people are more likely to apply it in their day-to-day lives.
The resources that we have available to us as GPs are limited, and unfortunately they're becoming more limited as time goes on. In terms of time, I literally have 10 minutes. You know, sometimes I'll take more time, but then that impacts on other patients. So we have limited time, 10 minutes, in which to deliver, you know, a comprehensive service, educate the patient, support them. It's just almost impossible.
We've developed a project that is going to target 15 families over the 2-year period and work with them in 6 to 8 week sessions over that 2-year period, and develop services and trying to get them to take self-management of their condition. We will deliver sessions around diet. We will deliver sessions around physical activity, emotional well-being, what is actual diabetes. We go in there and educate the full family, so all 3, 4, 5 members of the family. We make sure that they understand what the person living with diabetes requires, so that it's not just a healthy lifestyle for the person living with diabetes, but it's also a healthy lifestyle for the entire family.
One of the benefits of working with people from South Asian communities is the community infrastructure and the importance of word of mouth. So you might see that we've only reached a small number of people, but those people have been inspired and have gone out and spoken to another layer of people who have then spoken to another layer of people. So the kind of indirect benefit that we've been able to bring as far as reducing stigma and discrimination around living with diabetes, and also those kind of real crunchy things that could make a real difference to how people live with a condition. So how you cook your chapati, the size of your chapati, portion size is always a real thing that can be really visual.
When it comes to exercise, for example, again, research which was done at Glasgow, which I led from my thesis work, we demonstrated that South Asians are less fit than their European peers, and that this reduced fitness was associated with being more insulin resistant, a significant risk factor for developing diabetes. And while South Asians were less active, this reduced activity did not explain the reduced fitness. We found that South Asians, to achieve a given level of fitness, had to do more physical activity than a European. So they had to do more to get the same benefit.
So for the whole of Scotland, we've seen rates of both type 1 and type 2 diabetes increase year on year, and in the last 12 years the number of people with diabetes in Scotland has doubled. So it continues on an upward trajectory. And if you're from a South Asian background, then you are up to 6 times more likely to develop type 2 diabetes, and at a younger age. So your risk is increased over the age of 25 compared to over the age of 40 if you're from the white European community.
Diabetes has a huge impact on the NHS, and unfortunately, because of the kind of foods that we're eating nowadays, they have a high sugar content. The prevalence of diabetes is going to increase in the decades to come. That's going to mean a huge bill for the NHS and for just health services in general. So to focus on a group that is going to specifically have more and more diabetes within it, it makes a lot of sense.
If by getting the right advice to the right people at the right time, we can delay or even prevent diabetes from developing, progressing, and ultimately leading to complications which can cause people to have significant disability or even lead to early death. If we can demonstrate through these models that we can achieve that, then that's going to have major benefits not only in the individual but on health service as a whole, because we know that the cost of diabetes to health service is significant.
I think what we need to do is get the education out there, and I think that's important. Diabetes is not a death sentence. Diabetes can be controlled, it can be self-managed, and also if it's well managed, then you can reduce the incidences of complications from that condition as well. People are living longer with diabetes, and people are living longer without complications or as severe complications of diabetes as well. So it's important to get that education out there.
The kind of feedback that we're getting and the understanding and the learning about how people live on a day-to-day basis is allowing us to advocate and take those stories to the policymakers and the key influencers and decision makers in the NHS to say that these people aren't hard to reach, and that actually sometimes it's the services that are hard to reach. So it's allowed us to not just deliver the particular project and work with those families, but also to think differently about how we can deliver a range of services and how we can influence the policymakers.